Hello, everyone. Today's talk is on urinalysis, hydration, and obesity. So this is today's learning objectives. They're just pulled directly from the clinical skills document. It's worth taking a look over because that's sort of what you would want to focus your revision on. So what is urinalysis? So it's a simple bedside investigation that lets us have a look at the urine, essentially. We inspect the urine and also use a dipstick test, which can tell us whether the presence of certain markers in the urine. This is a cheap and easy test that's routinely performed in the hospital and is very useful in screening for certain conditions. So when do we do urinalysis? Well, we do it when we want to diagnose or manage conditions of the renal tract, infections, and metabolic disorders. It is primarily used as a screening tool, and it can be useful in UTIs, diabetes, kidney disease, dehydration, and hemolysis. So how do we perform urinalysis? Well, we just want to set up our equipment and PPE. As you can see in sort of the image on the right, you want to inspect the urine, looking for changes in color, clarity, and odor, as well as perform the dipstick testing, which involves submerging the dipstick that you get from the container fully into the urine and tapping off any excess urine. Then using the analysis chart and following the appropriate time intervals that are written on the chart. And then we interpret those results. If you want a more comprehensive summary, I recommend having a look at the Geeky Medics urinalysis guide. So how do we interpret these results? So inspection. So the color we typically expect in normal urine is the straw-colored urine, so just a yellow color. Dark concentrated urine might be the result of dehydration. Red urine might be the result of macroscopic hematuria, so visible blood in the urine. Porphyria, which is a disorder of heme metabolism and breakdown. Drugs and certain foods, such as beetroot. Brown urine, on the other hand, can be caused by bile pigments, myoglobin, and some anti-malarial medications. In terms of clarity, clear urine is what we typically expect. Cloudy urine would occur with sediment occurs in UTIs, renal stones, and high protein content, such as in nephrotic syndrome. Frothy urine, on the other hand, indicates significant proteinuria. So in terms of odor, a very offensive odor is indicative of a UTI, remembering that typically urine isn't very nice smelling. Sweet odor is indicative of diabetes. So in terms of interpreting dipstick results, I think it's worth looking at the different reagent squares and seeing what a result might indicate. So glucose is absent in normal urine, but it can be caused by, can be present in diabetes, renal tubular disease, and some diabetes medications. Bilirubin is absent in normal urine and present when there is increased levels of conjugated bilirubin. So that can often be caused by biliary obstruction. Ketones are also absent in normal urine and can be present when there's increased fatty acid metabolism. So any condition where you're using ketones as an energy source. So such as diabetes ketoacidosis and starvation. Specific gravity is an indicator of how much solute is dissolved in the urine compared to water. So essentially how concentrated the urine is. So the normal range is 1.002 to 1.035. So anything below this sort of indicates dilute urine, which can occur in diabetes insipidus and acute tubular necrosis. High specific gravity, on the other hand, indicates very concentrated urine. So dehydration, diabetes mellitus, and proteinuria. The normal range for pH in urine is 4.5 to 8. Lower than this might indicate starvation, diabetic ketoacidosis, and conditions causing metabolic acidosis. High pH, on the other hand, can indicate UTIs, conditions causing metabolic alkalosis, and medications. Blood. Blood is typically absent in normal urine, but can be present in UTIs, renal stones, damage to the urinary tract, myoglobinuria, nephrotic syndrome, and malignancy. In terms of protein, protein is typically absent in normal urine, but may be present in nephrotic syndrome and chronic kidney disease. Nitrites are also absent in normal urine and is present in UTIs. Urobilinogen, the normal range in urine is 0.2 to 1.0 milligrams per deciliter, and this might be increased in hemolysis or decreased in biliary obstruction. Leukocyte esterase is an enzyme produced by neutrophils, so we use this as a measure of white cell presence in the urine. It is negative in normal urine, but might be positive in UTIs or conditions that cause hematuria. So we're just thinking about any conditions that can cause white cell presence in the urine. Moving on to hydration status. So hydration status is also a pretty important aspect of clinical management. It can determine what type of interventions are given and sort of give us an indicator of how a patient might be affected by a disease or how we might want to manage that. So we divide our patients into 3 categories by hydration status. Hypovolemia is a deficit of fluid in the body, and that can be caused by poor fluid intake, excessive fluid loss, or third space fluid loss, which is when there is fluid that moves from the intravascular space to the tissue and organs. Euvolemia is what we describe normal fluid levels. Hypervolemia, on the other hand, is an excess of fluid in the body, and this can be caused by excess fluid intake or excess fluid retention. So how do we assess fluid status? So I've broken this up into history and examination. So with regards to history, the core details we want to focus on is the presence of thirst, so whether or not a person is thirsty, and any changes to their urine output, so any changes to the color or the volume of urine. Other significant details in the history which are worth having a look at when we're thinking about hydration status is bleeding, vomiting and stools, fever and diaphoresis, syncope and pre-syncope, eating and drinking status, symptoms of fluid overload, as well as any medical conditions or medications that can affect fluid levels, such as heart failure or diuretics. In terms of our examination, we're focusing on a few different core clinical signs and tests. So consciousness state can indicate how severe a patient's dehydration is, and that might affect how we manage that patient. Changes in weight can often indicate changes in fluid levels. Pulse rate is also important because tachycardia can indicate dehydration, and an increase of over 30 beats per minute can indicate hypovolemia. Blood pressure can be decreased in dehydration. Postural hypotension can indicate third space fluid loss. And if we remember, our definition for orthostatic hypotension is a reduction of greater than 20 systolic or greater than 10 diastolic within 3 minutes of standing. So in terms of tests that we can do, the capillary refill test involves pressing on the middle finger bed for about 5 seconds, then releasing and timing how long it takes for the color to return to normal so you can perform it on yourself. So normal is about 2 to 3 seconds or 2 to 4 seconds in elderly people. Skin turgor is another test, which is pretty easy to perform. It just involves pinching the skin and seeing how long it takes to snap back to a normal position. It should be instantaneous, but can be slower in dehydrated people or older people, which makes it a little bit less of a useful test, especially when it comes to more older patients. We can also have a look at the mucous membranes. So are the mouth and tongue moist or dry? It's going to be dry, which can indicate hypovolemia. We also want to have a look at the eyes, which can be sunken in hypovolemia, and the fontanelles in babies, which can be sunken in dehydration. We also want to assess the JVP, which can be raised in hypervolemia, such as in cardiac conditions like right-sided heart failure. And if you want a more comprehensive list of clinical signs that relate to hydration status, you can have a look at the Geeky Medics list. these signs tend to be a little bit more condition specific, but I think it's probably enough to just have a look at the ones we've listed in the previous slide. So just a few things to touch on in terms of nutrition, a couple of definitions. So understanding the difference between undernutrition and malnutrition. So undernutrition is not having enough to eat, whilst malnutrition is a deficiency of specific nutrients. And when we're performing a nutritional assessment, sort of an ABCD list we want to work through. So anthropometric data, so the person's height, their weight, BMI, their calf and mid-arm circumference, as well as their biochemical data, any clinical data, so physical changes, and dietary data, which can be assessed in a few different manners. Another important definition to understand is the difference between macronutrients and micronutrients. Macronutrients are what we're consuming in large amounts, like carbs, fats, and proteins, while micronutrients are things like vitamins and minerals. So another thing that's important in this topic is obesity assessment. So I've again broken this into history and examination. So in terms of history, you want to take a weight history from the person, asking the questions we've got listed there. You just want to ask about previous attempts at weight loss, as well as asking about their diet. So that can be quite difficult. So you sometimes just want to ask them about what they've done in the previous day, asking about certain food groups, any restrictions they have, questions like that, as well as their exercise, which can also be assessed over a week. It's also important to ask questions about if they've got a specific diagnosis of why they might be obese or any other medical problems that might cause obesity, as well as any medications that could be associated with weight gain or weight loss, as well as asking about family history and social history to look for risk factors for obesity. The other usual elements of the history are also required, such as allergies. In terms of examination, there's 3 core tests we want to focus on: the BMI, the hip ratio, and the waist circumference measurement. So the BMI, or body mass index, is a measure which is the person's weight in kilograms divided by their height squared in meters. Weight and height are measured with light clothing and no shoes. And it's important to think about that this test is somewhat limited, especially in those that are muscular or non-Caucasian people. And it's worth having a look at the classification. Don't bother memorizing it, but having an understanding of the values is probably a good idea. So 2 other measures: hip ratio is found by the waist circumference divided by the hip circumference. Waist is measured from the midpoint between the costal margin and the iliac crest, whilst the hip is measured from the widest part around the buttocks. And there's increased risk of chronic disease when the hip ratio is greater than 1.0 for men or greater than 0.85 for women. In terms of waist circumference, it's measured as described above. And there's increased risk when it's above 94 centimeters in men and greater than 80 centimeters in women. There's greatly increased risk of chronic disease when greater than 122 centimeters in men and 88 centimeters in women. So that's all about the obesity assessment, and that's also the end of the talk. So if you have any questions, feel free to send a message to us. But otherwise, thanks for watching.